Thank you for joining me for this short talk on the Erector Spinae plane block, which I delivered as part of RA UK's Plan A Blocks webinar series. If you want to see the full webinar episode, please tune in to the RA UK website, where you'll be directed to the website where all of the Plan A Block webinars are held. This particular webinar featured an introduction by Prof Ed Mariano. It was chaired by Prof Alan Macfarlane and featured another lecture by my colleague Dr Nadia Hernandez talking about rib fracture analgesia. So I do have some disclosures, none of which will impact my ability to deliver this talk, other than to say, if you're enjoying the content here, please do like and subscribe on the YouTube channel, and also check out the Block It Like It's Hot podcast that I do along with my colleague Dr Jeff Gadsden. So what is the paper that we're talking about? We're talking about this paper published in 2016. The QR code will take you there. This was when the Erector Spinae plane block was first described. And off the back of this, there has been an explosion of interest in this block. This was initially devised to come up with a technique to treat outpatient thoracic neuropathic pain. It had a couple of modifications, but ultimately the endpoint here was deep to the Erector Spinae plane, or deep to the Erector Spinae muscle above the transverse process, and this has now kind of revolutionized the way we think about fascial plane blocks. The editorial that this QR code will take you to was published by Dr Mariano and L. Bogdadley, and this forms the basis of the whole concept of Plan A blocks that has been endorsed by RA UK. The insert of the pictures that you can see there has been taken from this group of Plan A block posters. Again, the QR code will take you there. And the whole concept of the Plan A block idea is to make sure you can provide or produce competence in a small number of high-value blocks. So what am I going to be covering in this short talk? I'm going to be talking about the indications for the Erector Spinae plane, some of the contraindications. I'm also then going to take you through a whistle-stop tour of the anatomy and the sonoanatomy. We'll then look at the technique and some of the complications that could arise, and finally we'll end up with some tips and tricks. So let's start off with the indications. So what are the indications for the Erector Spinae plane block? Well, of course, it's been described or endorsed for chest wall procedures or analgesia. So what may that cover? Well, that may cover breast surgery, thoracic surgery, or even the treatment of rib fractures. But you know what? People haven't stopped there, and people have found other uses, some of them logical, some maybe less logical. People have used it for spine surgery, for abdominal surgery, and even for hip surgery. But where I'm most interested about this block is the fact that it can be used as a stepping stone to teach the paravertebral block, which, as you all know, I think is my favourite block, but for some reason people are not brave enough to learn this technique, and the Erector Spinae plane block is a way of getting them on that learning trajectory. As you may be aware, the choice of the Erector Spinae plane block as the Plan A block for chest wall analgesia caused some controversy, and I'm not going to go into that here, but people have asked, why don't we make the epidural the Plan A block? Why don't we make the paravertebral the Plan A block? Or maybe, why didn't we make the serratus plane the Plan A block for chest wall? And these are all valid concerns or questions, and I know that the authors didn't necessarily all agree on what the right technique should be, but they ultimately settled on the Erector Spinae plane block. Now, this is a similar principle to the serratus plane, so if you've learned how to do this one technique, you can take those skills and apply them to other blocks. It does have a shallow learning curve. Once you understand the nuances and the tips and tricks, it's relatively easy to learn and reproduce. It's also easily teachable. You've got some simple sonoanatomy to identify, and once you've mastered that, you can then use that knowledge to teach others. It's versatile, and as you will well be aware, it has been used for a whole host of other techniques, and it is low risk. The next thing I'm going to talk about is contraindications. So are there any contraindications? Well, thankfully there are few, but they're relatively obvious. Patient refusal for a block and local anaesthetic allergy are clear contraindications. Infection at the insertion site is something that definitely needs to be taken into account, and that may be significant enough for you to decide that you're not going to do it. But as with everything else, it's a risk-benefit discussion. If the patient has difficult anatomy. Now, what do we mean by difficult anatomy? It could be previous surgery, it could be insertional metalwork, it could be a large distance between the skin and the endpoint, or even maybe too small a distance. If whatever you try to identify in ultrasound is difficult, that may be a reason where you say, you know what, I'm not going to take the risk. And the last thing I want to mention here is anticoagulation. Now, anticoagulation when it comes to erector spinae plain block isn't necessarily the same as when you're thinking about a paravertebral or an epidural. And on this note, there's been some interesting guidelines and consensus statements that have come out. The first is from the Canadian Anaesthesiologist Society, who took a large group of experts, looked at a whole group of blocks, and they considered that the erector spinae plain block was low risk when it came to bleeding in the context of anticoagulation. And then ESRA and the European Society of Anaesthesia and Intensive Care came up with some really extensive guidelines. They classified the ESP block as a superficial block and said for superficial blocks, withdrawal of antithrombotic drugs for the block is not compulsory. You can look at a whole host of this information in this really nice BJA education piece by two of the REUK board members, Ashkin and West, and that QR code will take you to that paper where they talk about some of the nuances, some of the similarities and some of the differences between those guidelines. So let's now take a look at the erector spinae plain block anatomy. We'll start off here with the skin, and then we'll remove the skin. We'll see trapezius below that. Below trapezius, you've got the rhomboid muscles, and deep to the rhomboid muscles, you've got the erector spinae muscle group, and then deep to that, the transverse processes. So if we have a look in a bit more detail here, so here's trapezius, two components of trapezius there. We've got the rhomboids deep to that, and then three groups of muscles, spinalis, longissimus, and iliocostalis, that form the erector spinae muscle that we talk about. And if we zoom deep to those muscles, you can see the transverse processes. And of course, this is where we're aiming to deposit our local anaesthetic. So as I said, we want to get our needle and local anaesthetic in that plane over here, but we tend to talk about the erector spinae muscle as one muscle. It isn't one muscle. I've just shown you those three different groups, but we treat it as one for the purposes of sonoanatomy, which I'm going to cover now. So when we're thinking about sonoanatomy, there are some basic principles, and we need to be able to identify different tissue structures. So let's start off first with adipose. Now, adipose is relatively easy to identify. That superficial tissue is below the skin. It's the most superficial layer, and when you tilt the probe, its appearance doesn't really change. Deep to the adipose, you've got the muscle, which tends to look sort of steak-like, and as you change the tilt of the probe, the appearance of the muscle will change, and you'll see those glistening fibers changing depending upon which direction you catch them. Now, deep to that muscle, you want to be able to identify bone, which has a high acoustic impedance, so you see a bright white line and then a dropout artifact. So if you can identify those three layers with confidence, and you can appreciate the shape of the bone, you're on your way to being able to perform an erector spinae plain block. This large group of experts came together to produce an international consensus on anatomical structures that need to be identified for these basic Plan A blocks. And again, that QR code will take you to that paper. So what did they do? They defined two phases of scanning. An orientation phase where you aim to identify the structures of interest to get yourself into the right place to do the block, and then a block phase of scanning. So with regards to the erector spinae plain block, they said when you're orientating yourself, you need to be identify the rib and see that transition between the rib and the transverse process. You need to be able to identify the pleura and see where not to go, and the erector spinae muscles. And this had strong recommendations from that group. They had strong consensus on that. When it came to actually the scan that you need to produce to perform the block, there were only two components they said that group of people thought were essential to identify, and they had consensus on. That was a transverse process and the erector spinae muscles. So let's have a look at that. So here's an overlay that's going to appear over this ultrasound, and then a schematic diagram left behind. And you'll see again we've got that superficial layer with adipose, the trapezius, the rhomboid, and the erector spinae muscle group. Deep to that, you've got the transverse process, obviously deep to the transverse process, but under the shadow will be the rib. Most deep is the pleura, and between the transverse processes is that intertransverse tissue complex. Now, according to that consensus guideline, as long as you can identify the erector spinae muscle and the transverse process, you're good to go. So now let's have a look at what that scan might look like. So if we remove the skin and look at the tissue below and then apply a probe to that, have a look at the ultrasound machine on the right. You've got curved shadows of the ribs and the pleura, the cursor's on the pleura now. As we slide towards the midline, the rib shadow changes until it gets much more sort of rhomboid or much more rectangular. That's the transverse process. Going back to the ribs, you see they're curved, then go back to that transverse process, and you'll notice as we've gone towards the transverse process, that muscle bulk immediately above it gets thick and large. Let's put a colour overlay on that. Adipose, trapezius, rhomboid, and you can see that large, chunky erector spinae muscle group. And when you see that muscle group enlarge, you know you're over the transverse processes, as evidenced by that sort of rectangular shadow. Now that we've identified the sonoanatomy, let's look at things that are important for the technique. And we're going to start off with positioning. So you could start off with your patient in the sitting position, and you could decide to needle from cephalad to caudad or from caudad to cephalad, whatever suited your height, the level you were needling at, or maybe even the patient's position or their height or size. But there are some alternatives. You might decide that you want to have the patient in the prone position or in the lateral position as well. So there are a number of options. The only thing you can't do with this block is insert it with the patient in the supine position. Now this is one point I want to refer to now, and that's it's important to talk about block site marking. In the UK we have this scheme called Prep Stop Block as part of the Stop Before You Block campaign, and the idea is that you go through certain phases to minimize the chance of performing a wrong-sided block, and the QR codes at the bottom will take you to the original source material there. Now what the Prep Stop Block guidance said was that we're not supposed to add an additional mark for the anaesthetic block except if the block is near the midline at the back. So the erector spinae plane block would be the only time when this guidance says actually you can put a separate mark to indicate the laterality, and the reason for that is your assistant or the person who you're corroborating the block site with needs to have some reference point to check that you're blocking the correct side. So I wanted to point that out here. Next thing we need to talk about is the probe choice. And for many people, a linear probe is going to be just fine, because from skin down to transverse process, you're talking about 3.5 centimeters, and that's sufficient. But for some patients, you may need to use a curved array probe, and the bottom line is don't be scared to use it, because suddenly it makes your job much easier, gives you a wider field of view, you get a better view of deeper structures, and you can make sure you appreciate that endpoint much clearer. What about the needle choice? Well, I think there are two real choices here. You can use a standard regional block needle, which is short beveled, or you can use a TUI needle. Now, I usually use a TUI needle when I'm performing paravertebral blocks, so it would be not unusual for me to use it here, but I think the things you need to bear in mind, if you were to use a short bevel needle, as you can see, it's got a sharp point. If the sharp point makes contact with the transverse process, it may be possible that the orifice of the needle is lying within the substance of the muscle and hasn't gone deep to that fascia or the epimysium. So something to bear in mind. Most of the time when I'm doing this technique, I needle in plane, but you can, of course, needle out of plane as well. So essentially, whatever your comfort is, but be aware that you've got needle choices and you may decide to use one needle or another based upon your own preferences. This is a volume block. You need a large volume to make this work. And part of that is because you're aiming to get multiple levels. Part of that is because your endpoint for your needle is distant from some of the nerve targets, and you also want to create a depot of local anesthetic in order to have an effect. And also because you're not specifically identifying nerves as a discrete entity, you need a large volume of local anesthetic to bathe that area of interest. And I would suggest you use a minimum of 20 mils, but more like 30 mils or 30 cc's per side. Of course, we can't forget nerve catheters here, and this block, or this plane block, is a really great way for you to place a nerve catheter so you can have continuous regional anesthesia. And we tend to think now that if you're going to site a catheter in these places, in the same way that you initiate a block with a large volume, these catheters work well with intermittent boluses where you use about 10 to 20 mils as a minimum with each subsequent catheter administration. If you just use something with 8 to 10 mils an hour, it may be that as the initial bolus effect wears down or wears off, you may not be able to sustain the quality of analgesia. Now, we talked about needle endpoint. Well, there's a couple of different things you can do here. You can aim for the top of the transverse process. If you aim for the top of the transverse process, the needle comes in, it hits the transverse process, and it's possible that if you haven't gone deep to the muscle, that actually all you end up doing is creating an intramuscular injection, and you will see the thickness of the erector spinae muscle enlarge. So actually it won't look clean, and you won't get that erector spinae muscle lifting up off the transverse process. The alternative is you could aim for the corner of the transverse process just before it, and then aim to get really deep to that erector spinae muscle. And when you inject local anaesthetic, you see the stripe of local anaesthetic flow down the screen and actually lifting up the muscle. And it lifts it up in such a way that when you stop injecting, the muscle drops down and it looks sort of like pulsatile flow of fluid. So that's another alternative, and this has now become my preferred technique. Where do you have your endpoint? Well, many people would aim for T4 or T5, or even the midpoint of the surgical pain or the rib fracture. That's one option. Or it could depend whether you're needling cephalad to caudad or caudad to cephalad, and you might decide to be above or below the level of pain. So as you're injecting local anaesthetic, it flows in the direction that your needle is pointing. So that's something to bear in mind. Now it would be useful to have a look at some examples. So I'm going to start off with this first example here. Here you'll see the needle coming in as we're injecting local anaesthetic. You can see the muscle lifting up in that pulsatile manner. Every time we inject local anaesthetic, you can see the muscle lifting up and out of the way. And as we increase the depth here, it becomes much clearer to identify that. And then you've got a nice space into which you can thread a catheter. Here's another video courtesy of my colleague Dr. Jeff Gadsden. You can see here now he's just actually now over the top of the transverse process, and as he's injecting local anaesthetic, he's lifting elements of the muscle up out of the way. But you can also almost appreciate the lamination that exists there if you end up not quite being deep to the muscle, and you end up seeing that sort of expansion of tissue which isn't the muscle lifting up. But here you've got a really nice clear endpoint. What might a catheter look like here? Well, here's a needle coming in from the right-hand side of the screen. As we're injecting local anaesthetic, we're aiming to lift that muscle up, and now you're going to see a catheter coming up out of that needle. There's a catheter just about to emerge now, and now you can actually scan that catheter in long axis and actually identify its endpoint. So we've talked about the anatomy, the sonoanatomy, and some technique issues in terms of how to get your best options. What about complications? So actually, most of the complications are rare. Infection and local anaesthetic allergy are things, infection as related to having a catheter in there, for example. Local anaesthetic allergy, of course, we've talked about. It's very rare, but it could be there. You can get bleeding, and thankfully there are blood vessels in the root, but thankfully a lot of the bleeding that you may get tends to be superficial and compressible or easily evacuatable if there was an issue. Now I've put 2 question marks by the pleural puncture and pneumothorax because I can't quite understand how, if you're clear and you're confident and you're safe with your needle endpoint, there should be no way that the needle goes near the pleura. However, we know if you take a needle, a patient and a practitioner, anything is possible, so we have to quote and be aware of that. And lastly, I've talked about failed block. Now, I would consider this to be a complication, and one of the biggest things the detractors of the technique talk about is they say, well, the block doesn't work enough. There may be many reasons why that might be the case, but clearly a block that doesn't work as effectively as it should do, I would consider to be a complication. Now, do I have any tips and tricks to help you out with here? Yes, the first one is I think this is the type of block where it's worthwhile using a seeker solution, i.e. a non-active solution. It could be saline, it could be dextrose, something that allows you to identify the plane without wasting that depot, that volume of local anaesthetic that you've calculated the patient may require. Now clearly, we don't need to use a massive volume of the seeker solution, because if you use a larger volume, you're obviously going to dilute the total volume that you administer into that space, but certainly using a seeker solution makes sense here. Because we're injecting large volumes of local anaesthetic and there is that concern about plasma absorption, consider using epinephrine or adrenaline-containing local anaesthetic solutions. There are many commercially available solutions that have 1 in 200,000 adrenaline as part of that mixture. That may be something you want to consider. When you're going in with your needle, remember the endpoint is to lift the erector spinae muscle and its fascia up off the transverse process, and you want to see that stripe of local anaesthetic going across the screen. If you see that, you know you're in the right place. Now, I've already talked about aiming for the corner of the transverse process. There was a recent cadaveric study, and you can say what you like about cadaveric studies, but this one was interesting because it gave a different endpoint. It was talking about aiming in between the transverse processes. So let's have a look and see what this study is. This QR code will take you there, and they talk about two different endpoints. A medial, much more medial endpoint over part of the transverse process here, or an endpoint in between transverse processes here. And you can see how with this schematic diagram showing with a needle, you can appreciate how actually, if you were to go just a little bit further, it would be a little bit like performing an intertransverse process block. You're heading towards that intertransverse tissue complex. Now, when they did it on these cadavers and they evaluated the spread, they noticed with the needle endpoint between transverse process, you got much more extensive spread than the medial transverse process injection. And in fact, you got much more anterior spread towards the epidural space. So this is something to bear in mind. And it may be that a successful erector spinae plane block requires that deeper needle placement. We definitely need to be deep to the muscle, more like an intertransverse process injection. So why might that be the case? And of course, this brings into light a whole host of these concepts. We initially started talking about it with the MTP block, which is now called the ITP block. And again, these QR codes will take you to those relevant publications. But here the idea was, if you injected into that intertransverse tissue complex, you may well be above the superior costotransverse ligament, but we now know because of some detailed anatomical studies and CT studies that there are medial and lateral slits that can allow local anesthetic from that retrosuperior costotransverse space to get down in towards the ventral part of the spinal nerve and into the paravertebral space. The last thing I really wanted to touch on here is we can use the erector spinae plane block to help us learn the paravertebral block. What do I mean by that? Well, again, you can see here, you can use it as skill progression. You can start off by performing the erector spinae plane block. You can then get more confident and learn how to perform the ITP block by going just that little bit further into the intertransverse tissue complex. And once you've got that confidence, you can then place that needle deep to the superior costotransverse ligament and perform a paravertebral block. Now, here we go. You can see this demonstrated here. So there's a needle for ESP, go a little bit further for the ITP, and then go even more confident and go down to the paravertebral space. So each time you build your confidence, you can actually perform that block. Now, are there any unknowns? Well, there are some unknowns. What we don't really understand is how this block works. It makes sense that it would get the dorsal ramus because local anesthetic is in the vicinity of the dorsal ramus. But we're hoping it goes via that retrosuperior costotransverse ligament space to work to get the paravertebrals, and it may well then go on to get the sympathetics. But it may even go laterally and get the lateral cutaneous branch. Even though there's thick fascia there, we don't really understand enough about how it may work. Some people even postulate it has a systemic effect, but I'm not completely convinced by that yet. The other thing that's unknown is what the cutaneous sensory loss will be like. And that's because if we look at some of the studies here, here's one study, they took 12 volunteers, admittedly they hadn't had surgery, but took 12 volunteers and did a whole host of ESP blocks, and they only got dermatomal loss of sensation on the posterior thorax. And here's another study here, again this QR code will take you there. They took 6 volunteers and they got posterior and lateral thorax, but one patient looked like they may have had an ITP injection because they got really quite extensive anterior chest coverage. So the question I would pose to you is, do you need to have cutaneous sensory loss if the patient's comfortable, if the patient's pain-free after doing the block? And I would suggest maybe you don't. So let's finish up by doing a little recap on what we've just talked about here. So in terms of position, we'd start off with the patient either sitting, prone or lateral. I usually use in-plane kneeling, but you could use out-of-plane. You can start with a linear curve, but don't be scared of a curved probe if required. The needle length is somewhere between 50 to 80 millimeters, but use what you have. If you're going to thread a catheter, certainly no more than about 3 to 5 centimeters into that space, and usually you might want to have 20 to 30 mils as an initial dose to open up that space, and then if you're going to use a catheter, use a basal rate if you want, but definitely needs a bolus component. And then in terms of pearls and pitfalls, I talked about using a Sika solution, aiming to lift that erector spinae plane and fascia off the transverse process and aim for that corner or in between the transverse processes. So to summarise, this is still a new block and there are many potential indications. There is more and more evidence of safety and efficacy coming, so don't give up on it yet. It's safe and simple to perform. It does require a large volume of local anaesthetic and is well suited to catheter techniques, but it can be used as that stepping stone to learning the paravertebral, which would be amazing. So for more information, you can go onto the RUK website. We've got a whole Plan A block section there. I've linked you to 3 videos on YouTube, Jeff Gadsden, Keejin Chin, and my own. And also the QR codes along with that Block It Like It's Hot logo there will take you to our specific episode on the Erector Spinae plane block called Especially for You. So I just want to finish up by saying, if Albert Einstein was going to talk about the ESP block, he'd probably say, what we don't know is much more than what we know. Thank you very much for listening, and don't forget to like and subscribe.